Hello, my dear. I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. Today we have some OSCE in Obstetrics. Please try to answer before me. Okay, let us start with station 1. Please look to this picture. What is shown in A and B? This is the first question. The second question, mention 2 complications could happen in B. Okay, what is shown in A and B? Look to the A first. Picture A, show twin pregnancy, cephalic presentation. What about amnion and the chorion? This one, diamniotic, there is 2 sacs, diamniotic, as you see, 2 amniotic sac, so it is diamniotic, dichorionic, as you see here, each fetus has a separate placenta, so this is diamniotic, 2 sacs and 2 placenta dichorionic. So the complete answer would be in picture A, twin pregnancy, cephalic presentation, diamniotic, dichorionic. Okay, let us go to the next picture B. Okay, there is also twin pregnancy, but in one sac. They are cephalic presentation in one sac, so it is monoamniotic. As regard the amniotic sac, there is only one sac, so this is monoamniotic. What about placenta? There is also one placenta, so it is called monochorionic. So here I will say, as regard my comment on picture B, twin pregnancy, cephalic presentation, monoamniotic, monochorionic, monoamniotic, monochorionic. Okay, so what about the complication that may happen in B? Monoamniotic twins is a dangerous situation. Why? Because some complication may happen. One of them, entanglement of the cord of one fetus around the neck of the other, and sudden death of one of the twins may happen at any time during pregnancy. That's why the twins pregnancy, monoamniotic, monochorionic, needs good antenatal care and 2 frequent antenatal visits and delivery mostly at 36 weeks, because we are afraid from sudden death of one of the twins. What are the other complications? Congenital anomalies may happen. Twin-to-twin transfusion syndrome may happen. Shunt at the placenta, the level of the placenta, arteriovenous shunt. Twin-to-twin transfusion syndrome may happen. They may cause complication for post-twin. Okay, possibility of congenital anomalies is higher in monoamniotic twins, conjoined twins. So all these are complications. This is the answer of second question in station 1. Okay, let us go to the next station 2. Please look to this picture. What is the fetal presentation in this picture, and what is the treatment of this case in labor? You should concentrate very well in the picture to find the answer. This presentation is shoulder presentation. Okay, this presentation is shoulder presentation with prolapsed arm. As you see, there is prolapsed arm passing through the cervix, with palm of the hand anteriorly and the dorsum of the hand posteriorly, and the thumb directed to the right. Okay, this is shoulder presentation, right scapulo-posterior. If I asked you what is the position, you should say right scapulo-posterior. The denominator in case of shoulder presentation is scapula. Okay, how can I know right or left, anterior or posterior? Right is the side of the head of the baby. So in transverse lie or shoulder presentation, when you are asked about the position, the right according to the side of the head to the right side of the mother. Okay, what about the back? The back is directed posterior. How could I know? From this prolapsed arm, the dorsum of the hand, if directed posteriorly, so the back is posterior. If the dorsum of the hand was anteriorly, the back is anterior. In this picture, the dorsum of the hand posteriorly and the palm anteriorly. So the dorsum posterior, so the back is posterior. So I will say right scapulo-posterior. Right scapulo-posterior. And the thumb, in case of prolapsed arm in shoulder presentation, directed toward the fetal head. As you see the thumb here, directed towards the fetal head to the right. Okay? So if even I don't know that the head is here to the right side of the mother, I found the thumb here directed to the right, so I will say right scapulo-posterior. And I said how to know anterior from posterior by the palm of prolapsed arm. If the palm anterior and the dorsum of the hand posterior, so this is the back is posterior, so this is right scapulo-posterior. But he is asking here in the first question about the fetal presentation. This is shoulder presentation with prolapsed arm. If you wanted to complete the answer of another question of what is the position, you will say right scapulo-posterior. Okay? Okay. So, next question in station 2, what is the treatment of this case in them? Of course, shoulder presentation with prolapsed arm is an emergency situation. This is neglected shoulder presentation. And uterine rupture may happen at any time. So emergency cesarean section is a must. Okay? So the best management is emergency cesarean section and also correction of dehydration and signs of obstructed labor because patient in obstruction and the uterus impending rupture. So emergency cesarean section and the correction of the general condition of the patient. Let us go to station 3. Please concentrate on this picture and answer. What is shown in this picture? Okay, I'm sorry for some confusion in the picture, but if you concentrate, you can find the answer. This is the uterus. Okay, this is defect in the uterus, so this is uterine rupture. Where is the fetus? The fetus is out of the uterus. The baby is here. This is the placenta. This is the umbilical cord. This is loops of intestine. So the baby, this is uterine rupture, and the baby escaped inside the abdomen. And of course, this is a life-threatening condition from bleeding, shock, okay, and collapse. So how to manage such a case? course, blood transfusion, 2 wide bore cannula, emergency laparotomy. Everything should be done immediately. Okay? Laparotomy and remove the fetus from the abdomen and either repair and the placenta, of course, and then repair the site of rupture, or sometimes when the rupture causes much damage in the uterus, couldn't be repaired, hysterectomy may be needed. Okay, this is a very emergency situation because it is life-threatening, carries maternal mortality. Okay? If you asked me how can I diagnose such case of uterine rupture, of course, sudden stoppage of uterine contraction or labor pain, then abdominal pain related to internal hemorrhage. You can diagnose internal hemorrhage. You can feel the fetal part under the anterior abdominal wall. Usually, or almost always, the baby is dead. Okay? So you can't hear the fetal heart sound mostly, in most cases, or usually. Okay? If you are very lucky, the baby may still alive. If you have an emergency laparotomy, you may save life. But it is very rare to save life in such condition of the baby. Okay? But you are trying to do your best. So, ultrasound also diagnose the case. You will find the uterus without fetus inside, and the fetus is present inside the abdomen with no muscle wall surrounding the baby. It's easily to be diagnosed clinically and by ultrasound. Everything should be done in a hurry. Of course, fluid transfusion, blood transfusion, cross-matched blood, emergency laparotomy, everything should be done, and ask for help because this is a life-threatening condition. Okay, this is the answer of station 3. Go to the next. Station 4. Please look to this picture. And the answer. What is the difference between A, B, and the C? A, B, and C. The difference, as you see, is in the cervical dilatation and the effacement. In picture A, the cervix is not effaced. As you see, it is thick and closed. There is no dilatation. While in the picture B, there is partial effacement, about 50% or less, effacement in the cervix, thickening up of the cervix, and the starting dilatation of the cervix, maybe 2 centimeters. Okay? While in picture C, there is much thickening up of the cervix, effacement here reach up to 80% or 90%. Okay? And the dilatation also increased in picture C, about 6 centimeters on average. So, the difference between A and B and C is in cervical dilatation and effacement, as I mentioned. Okay? Okay. Let us go to the next, station 5. Comment on the type of placenta in A and B. Comment on the type of placenta in A and B. And second question, what is the mode of delivery in B? Okay, what is the type of placenta in A? what is the type placenta in B? In A, lock to the placenta. When I ask you any question related to the placenta, you should search for where is the site of the placenta? Is it normal site or not? The second, if there is any placental separation or retroplacental hematoma or not. Okay, any placenta penetrating the muscle wall of the uterus or not. So you should differentiate all different pathologies from each other. In the picture A, the placenta here implanted in the lower segment. This is a low-lying placenta because the lower edge of the placenta within 30 millimeter from internal os. It doesn't reach the internal os. It doesn't reach the internal os, but it is within 30 millimeter from internal os. The lower edge, lowermost edge, within 30 millimeter from internal os. So we call it low-lying placenta. So in picture A, when I comment on this placenta, I'll say low-lying placenta. Okay? There is no separation, just low-lying placenta. Okay? Okay. In picture B, the placenta here completely covering the internal os. This is mostly placenta complete centralis. And this is major degree of placenta previa and the most dangerous one. Okay? So, picture B, this is complete placenta centralis or major degree placenta previa, while in picture A, low-lying placenta. Okay? Okay. So, what is the mode of delivery in B? Mode of delivery in B is by cesarean section. Cesarean section. You may do cesarean section yearly before maturity if there is horrible bleeding to save life of the mother and the fetus. But if there is no bleeding, you are waiting for the maturity of the fetus, then do elective cesarean section. Of course, should be done with senior obstetrician experienced in such condition, because many complications may happen. What are the complications that may happen? Severe bleeding during cesarean section, during extraction of the placenta or delivery of the placenta. What else? We may be surprised by placenta accreta spectrum, which may need either conservative surgery by excision of the part of the muscle wall of the uterus with the placenta and the repair, or we may need to do hysterectomy if there is placenta precreta. Okay, so needs very equipped hospital, tertiary hospital, senior obstetrician has high experience in dealing with such case. Okay, because it carry many complications that may be life-threatening to the mother. Okay, everybody, this is the last slide. Thank you. This is my box published on Amazon, textbook of obstetrics, textbook of gynecology, contraception handbook, and the multiple choice question book. And this is my site on Amazon and my site on YouTube and my site on blog. Thank you.